to just sit there. I'm going to give you a couple of minutes, and I want you to list the cause of rotator cuff tears. Then I'm going to pick on somebody to actually. So you've got 3 minutes to list a cause for rotator cuff tears. Trying to see all the meeting. Okay, here we go. Okay, so we've got a list here. Let's start with Benjamin. What have you got there? Benjamin?
Hello, Prof. Can you hear me?
Yeah, I can. What have you got there?
I've got subacromial impingement.
Okay.
Trauma.
Yeah.
And then degeneration.
The degeneration. Okay, so there's 2 big broad groups. Is that all you've got, Benjamin?
Yes, Prof.
Okay.
I joined.
Okay, we're going to leave that. Francis, what have you got?
Hi, Prof. I subdivided it. So under trauma, I've got things like dislocation in your older population, iatrogenic, if that's a bit of a Hail Mary.
Iatrogenic, yeah. Hopefully not too many of those.
Hopefully not. Yeah, trauma other than dislocation, I guess. Also, I also put in degenerative. I'm not sure how much we see it, but infective, I guess, could also weaken the cuff.
Yeah.
Lead to tears. Yeah, that's what I've got.
Okay, Jono. You listening, Jono?
Yeah, Prof, I'm here, sorry.
Okay, tell me what you've got.
I got those, and then the only additional one I thought was maybe of calcific tendonitis, Prof. It was a bit of a flyer.
Yeah. Okay, so has anybody got, if anybody wants to tell me anything else?
Prof, inflammatory arthropathy.
Inflammatory arthropathy. Oh, sorry.
Okay.
Rheumatoid, Prof.
Rheumatoid, yeah. Inflammation. Okay, so you remember when you're approaching the exam, it's slightly different to when you're on the clinical scenario, but if you approach the exam, you should have your broad groups. What are the 2 broad groups? Are degenerative and traumatic. So if we look at degenerative, what are the causes of degenerative rotator cuff tears? So 1 is an aging process. 2 is a programmed apoptosis. So if your family member has a rotator cuff tear, which will come to, you have a certain percentage, it doubles if somebody in your family has had a rotator cuff. And then we break those degenerative into intrinsic and extrinsic. So the intrinsic is the rotator cuff, which we talked about, aging and proptosis. Extrinsic is subacromial impingement, which were going to be the Bigliani, type 2 and 3, you should know. And possibly, is anything else that could be giving you subacromial impingement and rotator cuff tears? Anybody?
Maybe if you've got like a GERD.
Yeah, so that's not going to give you the subacromial. Well, that will give you impingement. Yeah. AC joint. If you have a large AC joint, inferior osteophyte, you actually get almost a muscular tendinous tear of the supraspinatus. So that's impingement. And any other intrinsic ones? We've mentioned some of them. So 1 is calcific tendonitis. 2 is inflammatory conditions other than calcific tendonitis. So rheumatoid arthritis. Certainly in what we call the wet phase, there's a higher number of tears, maybe up to 20% of rotator cuff tears compared to 5% in the non-inflammatory phase. And the next is the traumatic. The traumatic may be acute traumatic or chronic, and they may be broken down to overuse or repetitive trauma. So overuse would be a throwing athlete who or rather a swimmer who does 2,000 lengths a day, that's an overuse injury. Or the micro trauma or repetitive trauma would be in a baseball thrower, why they would get rotator cuff tears. Let me just see there. Kudzai, why would what's the cause of the rotator cuff tear in a throwing athlete?
I think, Prof, it has to do with the mechanics that comes with the patient throwing. So it's more similar to an impingement, but it's because the greater tuberosity tends to rub underneath the subacromion, and the rotator cuff is in between. So it's almost similar to sort of like an extrinsic type of rotator cuff tear.
Okay, so you started off very well with intrinsic there. Who else wants to offer any other better explanations for rotator cuff tears in a throwing athlete? So we've got biomechanics and subacromial impingement. Why do they get subacromial impingement?
Prof, let me have a go. At my understanding, it's got to do with the capsule. So you get tightening of the posterior capsule, the humerus translates anteriorly, and then on certain movements that's involved in throwing, you get, as Kutsai said, impingement of the GT. It's often associated with a slap lesion as well. So slap, GERD, and impingement all part of the same subgroup for the same reasons in a throwing athlete.
Anybody else? Can somebody else add to it? So the altered biomechanics are multifactorial. First, if you have scapular dyskinesia, so in fact you have a weak or lower traps or rhomboids, the acromion is tilted forward and down, so you increase your risk of subacromial impingement. Secondly, if you have a tight posterior capsule, as you internally rotating at your end of your throw, it no longer can, you can't rotate any further. So what it does is push the head up and you get subacromial impingement. In the cocking phase, if you externally rotate and forward elevate too much, what happens is you get posterior superior impingement, where that's the infraspinator supraspinator junction usually hits the posterior labrum and can cause rotator cuff tears. Then you get fatigue failure from overuse, so repetitive throwings, and you get micro tears that happens. Or it's more dramatic when you get those really fast balls that they throw, is you actually have significant tears when you actually throw the ball, because you're overloading your tendon either acutely or repetitively under repetitive causes. Then you get micro instability of the anterior capsule, because you get fatigue of the rotator cuff muscles, and you start getting the labral problems and then the slap lesions, which can either be a traction injury, or some people believe it's the cocking phase of abduction externalization. So there's a lot more you need to know. So how many people got more than 5 causes of rotator cuff tears? Did anybody get 5 causes?
No.
Yeah, you see, so you guys, you must think more broadly when you're answering questions. And secondly, you need to do some reading up to see why people get rotator cuff tears. Okay, let's just go through a couple of cases. We've touched on some of this now. So I was going to do a poll on this, but I couldn't, because I'm not the sort of author of the Zoom meeting, I can't do a poll. So we decided. So the partial cuff tears are bimodal. What does it mean by that? Who's next on there? Who's KL? KL?
Hi, Prof. That's me.
Okay, Kim. Yeah. What's it bimodal?
Bimodal, so affecting older patients and younger patients. So there's a difference in the age distribution. And
why is that?
So young patients with acute trauma and older patients with degenerative changes. And
no, not with acute trauma. How many rotator cuff tears, Kim, have you seen in a 22-year-old?
Well, athletes, sorry, Prof, athletes.
Yeah, so it's an overuse injury. So it's a preventative problem, eh? The overuse injury, or usually it's an overuse or altered biomechanics injury. Okay, so that's a bimodal concern. And which ones are more common, articular or dorsal side?
Articular, Prof.
In which group?
Articular would be, assuming the athletic group, and
Yeah.
bursal more the elderly or
Then the
degenerative.
bursal-sided tears are thought to be more in the elderly from impingement, but your intrinsic failure actually occurs in the cable, which you should all know about, and that is in a more elderly patient. Can anybody tell me what the Elman classification is?
Prof, I think the Elman classification just determines the amount of in terms of size of the cuff tear. So I think it should be 0 to 3 millimeters should be less than 25%. 3 to 6 should be about 25 to 50. Then above 6 millimeters is 50% of the rotator cuff tear. In terms
Okay,
of thickness.
okay, good. So anything more about the classification?
I'm not so sure, Prof, but I think all it does, it tells you how much thickness in terms of thickness, and if it's more than 50, then you err towards surgical management. That's what we were looking for.
Okay. Hamad,
Sorry? Yes, Prof.
why do you think the Elman classification is important?
So I suppose it will determine your repair arthroscopically, whether you're going to do whether they're going to completely repair the tendon or just debride.
Okay, so that is one of the reasons, and also prognosis. So Elman's classification is really whether it's articular or bursal, so A-sided or B-sided tears, and then the size. And why do they use 6 millimeters? Because the average size of the articular footprint of the tendon is 15 millimeters. So that's why they're dividing it up into those two groups. I'm not sure if it's that useful. Yapi, do you want to say anything more about the Elman classification?
Yes, Prof. So I just found it, like I said, the implication of the classification is, like they said, the thickness of the tear and where the tear sits. So they advocate if you've got more than, you've got it's the difference if you've got a more than, I must just now think about it myself. So your bursal sided tear you must more aggressively fix than your articular side. So if it's a 2, you can still treat it conservatively or with a debridement on your articular side, as where you treat it more aggressively on your bursal side.
Yeah, so there's some people believe the bursal side tears are worse in the younger athletes.
Yes, yeah.
And even in the older patient, they think that it is. But Elman's classification is really to decide whether you should debride it or repair it. Okay. What do you think, Vishislav? Do you repair it? Do you debride it, or do you complete the tear?
I think you need to be guided by the size of the tear. From what you've said previously, is you kind of go according to, I think it was what you said, more than half of that you complete it. If it's well, you got to decide if it's partial or full thickness. So if it's partial and it's more than half, like you've said previously, then you kind of complete it and then treat it as a full thickness tear. I don't know if that's correct.
So if it's less than 50%, the recommendation is for debridement.
Yeah.
If it's more than 50%, recommendation is repair.
Okay.
And if it is bursal sided, more aggressive with the repairs.
Mm-hmm.
And what about whether you should take the tendon down or not?
Prof, I'm not sure.
Okay. Yeah, it makes no difference. Meta-analysis showed there's no difference if you complete the tear or don't complete the tear. It doesn't make sense for me to complete the tear. You debride like the tennis elbow, those angiofibroplasia changes, debride those away till you've got good tendon, and you clean it up and then you repair the tendon. If you look at this though, in the overhead athletes, the results are not supported by repairing 50%. In fact, the recommendation at the last meeting and the APSCA, which is the Australia, New Zealand, Asia Pacific group, sport group that I went and was talking to, there's a consensus that if your athlete has up to 75% of tear, don't repair it. They do worse. They have worse outcomes. So in the athletes, which is surprising because that's a group that you'd rather repair the tendon than leave them. They have more problems repairing than debriding them, and they'd rather come back and repair the tendon if it goes on to a full thickness tear. Okay. Right. So what are the outcomes? What do you tell your patients? Pravesh, what are you going to tell your patients once they've had a repair of a partial thickness tear or debridement? What are you going to tell them?
Hi, Prof. So we'll talk about failure of repair.
Yeah.
We can talk about the other complication regarding stiffness, axillary nerve injury. And
I'm just talking about the clinical outcomes of repair of tendons.
yeah, so then it will be failure of repair and recurrence of tear.
Yeah. Now, what are you going to tell them now? They're going to ask you, but is this operation going to work? I want to play tennis next month. What are you going to tell them? What's the chance of playing, or the chance of playing tennis?
So it depends on the size of the tear and the side and what we did. If we do just a debridement, I'll say yes, they can go and play earlier. If we repair, then we need to immobilize them and then do physiotherapy afterwards. So it will be a delayed return and slow return to sports activities. Depending on.
Am I going to play tennis, Pravesh?
Prof, you won't play tennis again if I repair your tendon.
If you repair it, maybe I won't be able to play. But if I repair it, you will. Okay, who gives me a percentage? Come, give me a percentage. Who's PB?
So, I can comment on that, Prof. So I suppose it depends also if the type of repair and if you're doing it arthroscopically or open. I think there's about a potential for 25% re-tear of the tendon, but a better or outcome with a double row repair versus single row repair.
Ahmad, you just shut yourself down, sadly, eh?
Oh.
So the first thing is, if you're doing a partial thickness, so I'm going to ask you, Ahmad, if you're a 22-year-old and you have a rotator cuff tear, whether you have a debridement or repair, what's your chance of returning to the same level of sport?
I would say, well, if you have a debridement or repair, so are you implying that there's a difference between the two?
Oh, so it's less than 50. Well, we've just said less than 50%. What's the chance of returning same level of report? What does it vary from?
So our thumbs up, I'd say anywhere between 40 and 70%, maybe. Chance.
Yeah, so it's actually a little down. It's actually down to even 17% in adolescents, but it's probably in the 20% and varies up to 60%. So that's probably because it's so multifactorial about the type of sport you play. What is the mechanism? Is there biomechanical problems? Can you correct them? Is there tight posterior capsule? A whole bunch of other things that go with it as well, not just the tendon itself. So the return to play is terrible. So in fact, that's why you have to try and prevent rotator cuff tears or rotator cuff problems in young athletes. They do really badly with surgery. So you're trying to well, the results are not good with surgery. What about the older group, Ahmad?
So the older group, it depends on the size of the tear. I think if it's quite a large tear, they have about a 70% recurrence rate. No,
not recurrence. What are we talking about? We're talking about partial tears.
Oh, partial tears. I was only thinking, I can't give you a number now, Prof.
So return to sports about 80%, eh? And to the same levels about 60%. So for the older age group, it's very different. So that's why it's very important to distinguish which two types they are and which groups they are, whether you debride or not debride. Okay. So that's very important. It's quite surprising. If you have a partial thickness cuff tear, what's the healing rate in the older population? Who can answer that? Who's HP? HP?
Yes, Prof.
Oh, that's you. That's you, Ahmad. Okay. Jan, Hiddeman. Jan?
Hi, Prof. So I think it's to be honest, I'm not 100% sure, but I think it's a lot. The healing is probably not that great. I'm not sure what the percentage is.
Yeah, so if you look at the partial thickness cup tear, the healing rate in the younger patients is better than the older patients. Up to 10% go into full thickness tears after repair of a partial thickness cup tear, which is surprising. You would think that wouldn't be a problem. It's even higher in some studies. The healing rate of, oh, now I've forgotten. What did I ask you, Jan?
I think it was the healing rate in the partial tears in the elderly.
Yeah, so what's the healing rate of conservative treatment in the adolescent or the teen or the 20-year-old, your athlete? What's your healing rate? If you get a partial thickness cup tear, what's your healing rate?
I would think it's better in a younger patient. I'm not sure the percentage though.
Yeah, it is actually. It's from 20 to 40% will heal. Okay.
Yeah.
So that if you do an MRI, you follow up you can't see the tendon tear. If you have a partial thickness cup tear in the older patient,
I would think it's worse because they'll keep on degenerating.
so within 2 years, 50% tend to progress.
Yeah.
And when we talk about progress, we progress in size and progress in symptoms. Okay. That's probably enough of partial thickness cuff tears.
Prof, can I just ask a question? That technique that you demonstrated when you took like a KY and you like caused some bleeding at the base of the cuff, it starts with an M, I've forgotten the name.
Police technique. It was described by foot and ankle by the sportsman.
Foot and ankle guy. Is there any trials out that show that might aid healing?
No, so no, there hasn't been any proof that it's better than anything else. And at the moment, let me just go here. Partial rotator cuff tears. Let's just go here. That's my wrong talk. Let me just go back. Which one is this? No, that's no, I've opened the wrong talk. Oh no, I'll tell you what, my hard drive's come off, so I can't use it. Okay, so if we go to the partial thickness cuff tears, 40% of athletes, so this study by Tibone, 40% of athletes have rotator cuff tears and MRI. They are asymptomatic. They're asymptomatic. And if you look at 50% of people who present with a symptomatic rotator cuff repair have an asymptomatic rotator cuff repair tear on the other side there in the older population. So we know it's not given. Sorry, I don't know what happened. I was going to show you that. So if you have a traumatic cuff tear as a youngster, you want to give it, if you operate on them early, you have worse outcomes than the group that you treat conservatively and operate at 6 months. So if you have a partial thickness cuff tear, you try and get the athlete to treat it conservatively, and 50% will get better. Not all healing on MRI, but 50% will get symptoms resolved. Of the 50% that don't, if you operate on them late, they do better than the group that have an operation early on. So we're very conservative on treatment, but they need a careful biomechanical assessment and retraining program, which starts with rest and biomechanical assessment and correction of the biomechanical abnormalities. Let's go back to this one. Right, so any other questions on partial thickness cuff tear? There's lots to learn. Who thinks they got 50%? If you didn't get 50% of answering all those questions, you need to do more reading, eh, guys? I suppose none of you are bold enough to tell me who got more than 50% there. Okay. Right, let's go to PV. That must be Peter Venter, I hope, eh? That Peter Venter, PV. Peter Venter?
Hi, Prof. Yes.
Okay, so posterior impingement and posterior lesions, you've heard me just talk about them. PASTA stands for what?
PASTA is for posterior articular supraspinatus tendon avulsion.
Partial articular surface tendon. Okay, okay. Not something you eat, pasta lesions. Okay, posterior impingement. So that was the one where I was talking about. In fact, if you listen to the ABC fellows, they were out here some time ago. They say there's no subacromial impingement. It's all posterior superior impingement. Okay. So what are the clinical signs for a pasta lesion and posterior impingement? Peter, or you had to knock off your kids?
So sorry, Prof. Yeah, I just had to get them out of the room.
No problem.
Yeah, Prof, I'm not sure.
Okay, Santa Marie. Okay, don't worry, Santa Marie.
Hi, Prof. Sorry, just had an issue getting my audio back.
No problem. What's the clinical signs of a pasta lesion?
Prof, so if you have a partial articular sided tear or a pasta lesion, you'll also have cuff tear signs. So you need to test your whole rotator cuff. You'll have weakness. So you need to test your supraspinatus, infraspinatus, your teres and your subscap. And
We do that always, sir. We do that always, Santa Marie.
Prof, specific signs for, I don't know if there's any specific things that you will find in a pasta lesion.
So if you get asked clinical signs, you start, remember how you go back to basics, eh? Look, feel, move. So basically, you shouldn't see any wasting. There may be some wasting if they're significantly painful of the posterior cuff. You expect some scapular dyskinesia or maybe abnormal scapular setting, because remember they've got a protracted, depressed scapula. And then on range of motion, they may lose internal rotation because that's the gird. They lose internal rotation, increased external rotation because it's a throwing injury. The next thing is they get pain on, not mid-arc pain or impingement. The impingement test might be positive, but not mid-arc pain. They get pain at full forward elevation.
Yeah, lifting overhead.
In the cocking position. So that's when they get pain in that position. And they may have mild supraspinatus and infraspinatus tendon signs. So a positive Job's test, maybe some pain and weakness of external rotation. So those are the signs of a pasta lesion. Yapi, you do agree?
Yes, Prof. Yeah, that's what I also have. Only thing is what they also describe is you get on palpation pain over the posterior glenoid. There might be an associated posterior labral injury as well. Due to that,
Yapi, I'm going to ask you, who else gets pain over the posterior glenoid margin?
Well, instabilities, rotator cuff tears, Prof. So it's not well, that's one of the other signs they describe, which I say, but I mean, I think it's non-specific, but that's one you can add to the palpation part of look, feel, move.
Yeah, so I'm asking you, who gets just posterior pain? If you examine a shoulder and they only tender posteriorly, what do you think of?
Well, posterior instability, Prof.
Yeah.
No, I'm not sure which ones. Just
you must think of a ganglion, eh? A posterior, so posterior instability, posterior labral tear, and a ganglion. Early arthritis sometimes at the back may give you some pain, but when you get isolated posterior instability, you must think of a ganglion at the back and a labral tear. Eh? Those are the two things, and calcific tendonitis. I mean, anything give you posterior pain, but when it's very isolated there, you must think of those other things. Okay, Santa Marie, you haven't finished yet. What's a Bennett lesion? Bennett lesion, Santa Marie, Vishislav, start thinking. Okay, what is it? Who knows what a Bennett lesion is?
It's an exostosis over the glenoid.
It's what?
Is it the osseous?
Exostosis over the glenoid. It's a piece of, it's like an osteophyte over the glenoid, over which the tendon rub and you get a pasta lesion.
Why do you, no, not quite. Why do you get it? Why do you think they get it then, Pravesh?
Might be because of a tight posterior capsule, so that traction ossified lesion.
Yeah, so it's traction of the posterior labrum on the posterior glenoid, and you get heterotopic bone or ossification underneath there. Okay, and turn towards, and they get a micro tear of that labrum at the same time. So in the throwing athlete, how do you fix that, Yapi?
Fix a Bennett lesion, Prof.
Yeah.
Shoot. I don't know. So firstly, Prof, I think you must first go see if there's posterior instability, if there's a labral tear. I think I'll start with.
No, Bennett lesion doesn't have posterior instability.
Then I'm not too sure how you fix a Bennett.
Yeah, what you take is take the labrum down, remove the bone, and repair the labrum back on. And you do a biomechanical rehabilitation for tight posterior capsule, rotator cuff strengthening. Okay, because there's a traction. They think it's from a traction from the follow through, maybe a tight posterior, but the follow through when in the throwing athlete, so it pulls on that posterior capsule. Okay, that's our management options. Okay, enough partial thickness cuff tears. Let's see who another one. Okay. So we were talking about this a little bit earlier. Mohammed, Daw, what's the incidence of rotator cuff tear in a 60-year-old and an 80-year-old? Asleep there. No? Michael, do you want to help him out? WhatsApp him.
Yeah. So roughly 60% of 60-year-olds and 80% of 80-year-olds have.
No. What is it? What is it?
That's the number I had, at least. Basically.
It's about 30%. That's too much at 16. About 30%.
Okay.
And probably you say about 70 at 70%. There's a small partial thickness to full thickness test, but it's definitely not 60 at 60.
I suppose not complete. Sorry, I didn't read the complete part. Apologies.
Yeah. So it's reduced. So it's a natural aging problem. And do you know what your risk factors of developing a tear later are, besides family history, which we've discussed?
So this could be anatomical risk factors. So as you said, if you've got a acromion type, a Buglioni type 3, a hook type acromion, or if you've got, I'm trying to think of other anatomical risk factors apart from, I'm trying to think of some more.
We said AC joint arthritis. Anything else?
But AC joint arthritis is also an age appropriate thing. Most people after 40 get AC joint arthritis. Or at least AC joint degeneration after the age of 40. That's also a common aging process.
Okay, while you're thinking, I want everybody else to outline your management plan. You get presented with the patient with the full thickness degenerative rotator cuff tear. You've got 2 minutes to write it down, and then I'll pick on somebody to do it. Well, Michael, you can continue. What are the other risk factors? What about smoking? What about obesity? What about
genetics? So systemic risk factors, as you said, diabetes, gout or pseudo gout, smoking. I think alcohol is a risk factor. There's some certain medications. I think
so antibiotics,
ARVs, some of the epileptic drugs.
I don't know. You sure for rotator cuff? You'll have to show me that evidence. Hypercholesterolemia is one of the other ones. So in fact, it's smoking. Out of all of them, it's disputed. Quite a few of those are disputed, but they've all been brought into possible cause for getting a degenerative rotator cuff tear. Okay, Kim, what's your outline for a full thickness cuff tear in a 60-year-old? All of you can mark yourself against what she's going to tell you.
Hi, Prof. In a 60-year-old, I'd obviously first try non-operative measures, physiotherapy, NSAIDs, activity modification, rest of the joints. You could try subacromial corticosteroid injections, or obviously you need to look to see if there's obvious anatomical causes that you could address, like the AC joint or calcific tendonitis. And then I would probably give them 3 months at least of physiotherapy trial, see how they do. It depends on the patient, how keen they are to get back to their sports. Then you would offer them surgical options. I think you'd start with the impingement, so subacromial and AC joint excision.
So what do you think about cortisone injection?
So it won't treat the tear. It will help with inflammation, but it's not going to address the tear itself.
So why give it then?
Symptomatic management of the pain and inflammation.
Yeah.
To help them with physiotherapy.
How long does it work? Yeah, exactly. So there must be a goal for giving the cortisone. You want to decrease the subacromial bursitis or the inflammatory changes to allow them to do the rehabilitation. Okay. You have to do the rehabilitation. What is the rehabilitation?
I'm not too sure, Prof, but it would probably be rotator cuff.
So you must correct the scapula. Remember, so you must do scapular exercises. Yeah, you must do strengthening of the deltoid, and you must strengthen infraspinatus and subscapularis and balance the shoulder, and then an eccentric program for the rest of the tendons. That's the goal. With one other thing, what's missing in that? Mohammed, back with us again. Kudzai, what else? Deltoid, scapular, rotator cuff, and very important.
Lost day, Prof.
What? A stretching program. Remember, they have tight posterior capsule. They lose internal rotation. You can't have it. They get impingement from it. So they must do a stretching program, especially with the tight posterior capsule. Not even just, it's not just the throwing athletes that get a tight posterior capsule. If you look at the patients with impingement and rotator cuff tears, they tend to lose internal rotation rather than the other range of motions. So when you see somebody who loses external rotation, abduction, internal rotation, what do you think of, Kudzai?
If they lose external rotation, Prof, I think it's either the tightness of the anterior capsule, I think.
Yeah, what diagnosis? Kudzai?
That's a frozen shoulder, Prof. Or they have
early osteoarthritis. Early osteoarthritis. Okay. No, older patients. So that's good, Kim. You actually, that's right. You must treat it conservatively. There's lots of evidence to back up that there seems to be improvement over time. What's a concern, though, about the conservative treatment? If you look at that, John, what's a concern?
Prof, you have to keep an eye on it, because the concern would be the long-term sequelae of cuff arthropathy.
Yeah, what percentage?
Prof, a huge percentage of people are found incidentally to have cuff tears. So I think if you had to look at exactly who has cuff tears and divide that by how many people get cuff arthropathy, I think it's actually quite low, Prof. I'd say.
Does anybody want to give me a number?
Maybe.
Yeah.
I think it's about 40 to 50%. I think with the full cuff tear.
Within 2 years, 50. I told you, 50% progress.
About 2 years, yeah.
Size. At 22 years, 75% will have cuff tear arthritis on X-ray. 22 years, so we know it will progress. So that's the stats we know. Charlie Rockwood showed that 4 to 10% will have rotator cuff arthropathy within 10 years. That's all we do know. So you don't want it to get bigger in size. So it starts making you, it starts changing some of your clinical decision making. Who would you operate on and why? Right, let me ask somebody, sorry. Francis, who would you operate on?
If your patient's higher demand, so these are all patients with complete tears.
We said we've got a full thickness tear already.
So probably the patient that is higher demand, if it's their dominant side.
Those haven't been recommended, maybe high demand.
Yeah.
You want to operate on the people who you think are going to progress in tear size. You agree? So who would that be? Ashley, who would that be? Whose tear size is going to increase?
The younger of that older group.
Did you heard what we said earlier? The young ones don't tend to progress so quickly. Eh? The older patients tend to progress. But you would tend to operate on the younger patients, yeah, one. And who else? Ashley?
Prof, I'm not sure. You mean progression when there's already a full thickness?
Yeah, so they got a full thickness tear. There's some that won't progress.
I'm not sure, Prof.
Yeah, the tear size is more than 1 centimeter. If it's retracted more than 1 centimeter, there are maybe some MRI signs. Yopi, which ones are more likely to progress? So if it involves a biceps anchor, if it's extended to infraspinatus, if they have weakness of external rotation, that's probably because it means it involves infraspinatus and it's probably related to tear size rather than 1 centimeter. So we know those group, if you do an ultrasound and you see those parameters, I'm a little bit more aggressive in doing, especially the young, as you say, the young and the physically active patient. But there's no evidence that the physically active patient does worse with physiotherapy than the other group. Okay. Jimmy, do you want to say anything on that?
Prof, just to clarify, are you chatting now about, are you discussing who you would be more likely to operate on with full thickness tears, or are you talking about rotator cuff tears in general?
No, rotator cuff tears in general. But every time you see a patient, you have to make a decision. And your decision has to be based on some decent, as best evidence as you can. So when you've got the 60-year-old who comes in, who's playing tennis, non-smoker, fit and healthy, and he's not going to die likely in the next 20 years. He's been vaccinated, had both his vaccinations, and he wants to, I mean, he's fit and active, and he's now got a 1 centimeter tear. You tell him you have a 50% chance that this tear will increase in size in 2 years. It does not heal. We know that it does not heal. And the downsides of the surgery are the length of rehab, the pain, but 80 to 90% of surgery is successful. If you compare that at a 2-year period, probably 60% of conservative treatment is successful, plus an increased risk of tear size progression. So you got to weigh up, why are you waiting around for him to do? So you have to be honest to them. So you can weigh up that chance and say, listen, you try conservative treatment. So the conservative treatment's all well and good. You improve your range, your strength, and it's everything, but your pain's still at 3 months. So why don't you just get on and do the operation? Because you've got an 80 to 90% success rate. But you do have a risk of sepsis, frozen shoulder, failure of the repair. So you have to balance those all out with the patient and what your decision making is going to be, because it does make it different. If I've got a 2 centimeter tear of my rotator cuff, I'm not waiting for 2 months of physiotherapy. I want an operation. And I want to be fixed because I know I've got a 60 to 80% chance of tendon healing and 80 to 90% chance of good clinical outcome. While I'm more likely to progress as a 2 centimeter tear, I've probably got less chance of healing, but I've got more likely chance. So why am I waiting? Plus, they've shown if you have repeated cortisone injections, I'm talking about 2 or 3, not 6, 7, 8. I'm talking about 2 or 3, your infection rate and your healing rate goes down. That's been shown, was presented at the SAOA last year by the guy from Joburg, and a big meta-analysis and analysis of this. So you don't want repeated cortisones in your rotator cuff. unless there's a specific goal for it, like you're going away on a holiday and you want to just be pain-free. So I'd be very reluctant. There's no evidence for PRP, testosterone, growth hormone, anything else to improve that tendon from healing back on there or prevent it from tearing. And that's been shown. Eh? There's nobody shown PRP. So sometimes you've got to make some decision for the patient, and he's got to make those risks, the risk of surgery versus what he knows what's going to happen. The natural progression of the rotator cuff is probably to increase in size. And not all become symptomatic though. So that's why I'm saying you can have an algorithm, but sometimes you got to balance it out with what you see in front of you. If you're an overweight diabetic smoker, I'm going to try conservative treatment first because your surgical outcomes are worsened. But at the same time, we know it's more likely to increase in tear size. So why not try and fix it now and have a 60% good success than waiting for a bigger tear? Now it's 5 centimeters. Okay. Any more thoughts on massive rotator cuff tears? I mean, degenerative rotator cuff tears. Any thoughts? No thoughts?
No.
I just want to, okay. So let's go back. All right, so let's move on to traumatic rotator cuff tears. Bayanda, what's the terrible triad of the shoulder?
Evening, Prof.
What's the terrible triad of the shoulder?
Would it be the? I'm having a guess. The superior suspensory complex.
That's right, but not the right one, Bayanda. That's okay.
Okay.
Okay. Brad Bonner.
Hi, Prof. I think is it the shoulder dislocation, cuff tear, and brachial plexus injury?
Yeah, axillary nerve injury. Yeah, so that's a terrible thing. Yapi put this in, so I'm not sure. What's your management plan if you have an associated tuberosity fracture or one without a tuberosity fracture?
So, Prof, I just put it in there. So usually you say when it's more of an acute tear, you'll tend to be less or more aggressive in surgical fixation than your conservative management. And then just on the tuberosity, when would you fix it? Does it still imply displacement of more than 1 centimeter with 45 degrees? Okay. Or would you tend to put a screw through it or use double row anchors with and around a post? It's just sort of on the discussion or the management plan of the...
Okay, let's go to the terrible triad. We don't often see one. We saw one, I think, the other day. So if you have a terrible triad, you must get on and repair that tendon. Eh? That may be the only functional part that he'll recover, but you never know if the suprascapular nerve is injured as well at the same time because they present with the same problem. They go over pseudoparalysis because they've got no deltoid, no rotator cuff, and you're not sure which part of the plexus. So you've got to examine that plexus very carefully to see if it's an isolated axillary nerve or not. But you must repair the rotator cuff. So if the axillary nerve recovers, the axillary nerve doesn't recover, hopefully the suprascapular nerve is not damaged or it's not a complete C5, and then you've got some function left by having the rotator cuff. But I can tell you, if you leave that within 3 months, that tear is not repairable. The tendon is not repairable. So we've seen one of them. So what happens is they get diagnosed with the axillary nerve and they miss the rotator cuff tear. So you need to check for external rotation. And in fact, you need an ultrasound of the rotator cuff in the older patients. And if you have an axillary nerve palsy, please do at least an ultrasound if there's no greater tuberosity fracture. So that's the only thing that I would learn from that. I just wanted to, let me just quickly go here. I'm not sure, I must have closed it when I was opening. I wanted to show you the rotator cuff tears so we can see the different parts of what the problems are, just to illustrate some of the problems. So if we look here, you can all see this is the biceps. This is the supraspinatus going over the top. There's the labrum, and you can see the insertion of the footprint. Just hold on, I don't know how to get rid of this now. Hold on. Let's go. Okay. So that's the normal rotator cuff. If we look on the outside, this is subacromial impingement. This is, for me, I can't understand how physio makes this better way. We can see that's the coracoacromial ligament, and this is the top of the rotator cuff looking from the back. Here's the subacromial bursa, the space. There's the ligament running down from superior down to inferior, and you can see this is a clear impingement. You can see why cortisone will take away some of the pain, but I don't see how that mechanical change is actually made better by physio, but it's been well documented that it does. This is even more severe impingement. Just move that away. And we can see here, this is the opposite shoulder, and this is flaps of tissue. This is a bursitis here. Look at this bursitis that's there. So this is why the dilemma about, is it the rotator cuff that's causing the problem, the pain? Is it the tearing of the tendon? Is it the bursa? That's the bursitis that we can see. You see all this sort of red floating seaweed type stuff is the bursitis, or is it actually the mechanical impingement on the acromion and increased interosseous pressure or tuberosity change? So we don't know why, what the causes of pain and from it. So if you have a look at this, this is from a lateral portal. You can see this is a supraspinatus tear. This is a stable tear, degenerative tear. You can see the tendon changes, supraspinatus here, infraspinatus, and that's the size of a pencil. That's a small tear. What's the name followed up, 10-year follow-up on patients who had an acromioplasty for this. And 80% didn't even know which side their shoulder was operated on, because they got better without a repair of the tendon. So it's not just about the tendon, but the tendon size will get bigger. This tear is very different. You can see it's a thickened tendon, and it's an L-shaped tear, and it's completely off the tendon. It's retracted. If you leave this is going to get stuck down, and you're not going to be able to repair it later, and it's becoming atrophic. So that's why everybody has a different tear shape, tear size, and all the other sort of genetics that go with it make you make different decisions on people. This is probably traumatic, but it can't be that traumatic because you look at the rounded edges. So there must be some chronic element to this, the repair. Here we have another tear. This is not, it's not that much big, but look how thin and defrayed that tendon is. This is a degenerative older tear. You can see it just frayed. So treating this, this is failed conservative treatment, but this is probably what that first tendon that I showed you is going to look like in 2-3 years' time. It just progressively gets thinner and smaller and retracted and bigger in a tear until you get a position that you have a tear like this, which is massive. So we're looking from the lateral portal, that supraspinatus that's been pulling on there. Look, it's retracted right to the glenoid margin. See, we're trying to pull out. Look how thin and flimsy it is. There's a supraspinatus muscle, and we can't bring this back. So each tear, I think you've got to, there's so many different aspects of it, and you can't tell just from clinical examination or ultrasound or MRI. Some of the findings are at the time of surgery before we make some of the decisions. But you need to make some decisions before on what you think the tendon's going to look like and which age group. I just wanted to go back to one of the comments was that by Ahmad is that you need to do a double row repair. That's only been shown in massive to large tear, and it's only been to show slight improvement in outcome. So a single double row repair has been a big fight amongst surgeons for a long time. I tend to do most of them double row, and even the partial thickness now I tend to do double row because I think you get a better footprint push down and you take the knot away from the subacromial space. So there's reasons why we do double row and single row, but we'll talk about that next time. I'm not going to do anything more. It's like 4 minutes to go. Any questions that you want on asking on rotator cuff? We'll still do massive rotator cuff tears. And I tell you what, some of this is going to be covered on the Wednesday nights on the registrar program that Cameron's and he's going to put up. We're going to do 20 minutes. Cameron's going to present a topic and we're going to just discuss it. It's only going to be 20 minutes. We're not going to do like we did last year, and it's just to discuss the topics. So it means you can join it, and you can come, and it's going to be posted on a video somewhere. You can go and look at it later. So it's not going to be like it was last year showing the surgery. Okay, any questions? I'm not going to do anything further.